turn it around, there are some plans that have insisted on failure of an existing agent before you can start a new agent.
And that's where a guideline would help, because if there was a national guideline or a guideline that actually said every one of these can be first-line therapy, or these 4 based on the effectiveness, but maybe these 2 products based on side effects should not be used first because the side effects, and I'm really just throwing this out saying that's where a guideline could actually help. And there are guidelines that say you can start on different diseases. You can start on all these medications are considered first line, these medications are considered second line. It really would.
So it depends on what the information was that led to the approval by the regulatory authorities. And the FDA and the Europeans do this a little differently in terms of what's first line, what's second line. But it doesn't mean that they're interchangeable.
Absolutely.
And so, for example, I think there's a difference between high-dose interferon and low-dose interferon. And so being forced, and I will use low-dose interferon in some individuals if it works out that that's something that they're going to take, as opposed to not taking something else, and that's fine, or if their disease doesn't worry me a lot and such. But I wouldn't want to be forced, say, you have to take this and fail this, whatever that means, before I can get you on what I really want to put you on. And I think there are data to support the difference between those 2 agents, just like I think there are data to support whether GA and high-dose interferon are the same, or whether GA, and now we have data to support that GA is superior to low-dose interferon. And to answer your question about combination, we published a paper 2 months ago to suggest the combination of interferon and GA isn't better than GA alone.
So, and just a bit about that, pretty interesting, because in where my health plan is, and this started at least 5 or maybe 6 years ago, that GA did become 52% of all patients just started off with GA. Like you, I actually looked more at the studies on high-dose interferon and thought, you know, that would be the way to go first. But for some reason, 52% of all new patients are started on GA.
But that follows the data, actually. The data suggests that GA and high-dose interferon are equivalent, and that the safety profile is easier. It's just a matter of more injections.
And they're equivalent as far as decreasing the acute attacks. As far as, again, what we talked about before, the long-term disability, the data is not there yet, or at least if it's there, we haven't seen it there.
No, the data aren't there for long-term disability. And the problem with the long-term disability studies, all of the agents that have been around for a long time have long-term data. It's just not particularly compelling data. It really, what it tells you is people who do well do well. And there's lots of people who do well, which is, I think, something Dr. Coy was alluding to earlier, that we have people who are doing tremendously well now for up to 20 years. But that's what the long-term data tell you, and so you only can use it to an extent.
You know, and I don't disagree with you on the difference between high-dose, high-frequency, and low-dose, low-frequency interferons. But when you look at the utilization, and in our employer collaborative, we don't have a preferred agent in the MS category, at least a preferred injectable. So they can get GA or they can get any of the interferons that are out there. GA is, like yours, number 1. About half the market is GA. Next is a low-dose, low-frequency interferon is number 2. So, you know, despite what we say about the potential, the reality is those are the drugs that are being used in the community. And those are the ones that, quite honestly, we have made by default, you know, the first agents out of the box, because that's what our clinicians are using.
But that's going to change.
Oh, I think
We're
it
now
will,
in the era of
undoubtedly.
the orals. We
Yes.
have 3 orals, and that's going to increasingly change. I have frustration in not being able to use an oral first line. I've had some problems with insurers, and I don't understand that.
I think some insurers, when we only had 1 oral first line, were concerned about the side effects of that drug. I don't think they were as concerned about the efficacy. And quite honestly, they looked at the standard still being a GA and the interferons, and were hesitant to allow that drug to be out of the box. And some of it was a pure cost issue. that drug was not priced competitively with the
So let's
others.
come back to that.